Hey, good morning, everybody. Thank you for joining us for this first class, the Pediatric Ventilator Management class. Pretty excited to get this thing started. We're just kind of waiting for everybody to come on in. But over on the left-hand side of your screen, if you could just simply leave me a little comment in the class conversation page and just say hello. Let us know that you can hear us and that everything seems to be working just fine. We're going to give it a few more minutes for people to come in and join the class, and then we'll get things going. So I'm going to go ahead and just mute this for a few more minutes while everybody comes in, and then we'll get things kicked off. Hey, Melissa.
Hi.
Sorry for the confusion this morning. We'll do our best to kind of work through this. Let's see here. Okay, so Melissa, yeah, you should be able to control the PowerPoint now, and you should be able to navigate around just like you would previously.
Okay, so I just see a box with you and a box with me.
Yep.
No PowerPoint.
Yep. So in just a minute, I'll switch over.
Okay.
So do you just want to kind of introduce yourself to the group, and then we'll kind of get started with the class?
Yeah. Hello, guys. Thank you so much for hanging in there with us. We're really good at saving lives, maybe not great at navigating this computer issues. So we're working it out. We're figuring it out. But thank you so much for giving me this opportunity to talk to you guys in this transport world. So I'm a flight paramedic. I work with Sean here in Colorado, and I'm also a respiratory therapist. I have NICU, PICU, and adult experience. And starting next month, I'll be going back and working full-time as a pediatric and neonatal respiratory therapist. So I'm super excited about that. So my company is called Beyond the BVM, and I started it just to I identified a need with my colleagues. Everywhere I went to go work, I had a lot of paramedics asking me for a lot of help with the ventilator. So a lot of the critical care classes and things like that don't really prepare you for real life ventilation. There's lots of easy book answers, but I knew a lot of my colleagues were kind of set up to have to work really hard when they start their career, and they don't really need to. You know, our ICU nurse colleagues get a lot of hands-on experience in their 3 to 5 years before they show up for these jobs. And our paramedics, as paramedics, we don't. And when I went through paramedic school, I realized, you know, we spent about 25 minutes talking about ABGs, and that was about it. And not even much time talking about even how to bag a patient. So that's kind of where my vision came from, that I think that our paramedics deserve a little better shot setting up, and we're super good at this job. And we just need a little bit more help getting started and getting prepared for this kind of job. So that's where my company comes in, Beyond the BVM. So thank you, Sean, for hooking up with me and allowing me to do this with you.
Oh, you're welcome, Melissa. The vast majority of people that come in and join our community here ask for vent training. And so when you told me that you were going to start, super excited, because I know that so many people out there in our community need this kind of training. And I know that you kind of teach the whole spectrum from adults, you know, basic and advanced all the way through pediatrics. So super excited to kind of kick it off with, you know, kind of the worst of the worst.
Yeah.
All right. Well, I'm going to switch the screen over, and you should be able to kind of drive with the PowerPoint, and I'll let you take it away. Guys, if you guys have any questions, you can always put it in the chat box. And you can also, if you're on the computer, you can also use the raise your hand tool at the top of the page. Cool. Take it away, Melissa.
All right. So this is, guys, I don't mind stopping my PowerPoint if you have a question about a certain slide, or if you want to ask in the middle. You don't have to save your questions to the end. So very informal. So my talk today, I just wanted to go over a little bit about some differences with kids versus adults. I kind of go back and forth. For a while, I think I bought into the turning kids into such a different kind of animal, but I think that set us up for failure. So I don't like to, I almost like to consider them a little bit of mini adults. Every adult has a different anatomy. Our kids all have different anatomy. So that's kind of how I like to do this, is just start talking about a little bit why kids are different and also why they're the same. And you'll see that when we go start talking about actual ventilation strategies, and we're picking our cc's per kilo, what we want to do with these kids. There's not a whole lot different. They still have restrictive processes and obstructive processes and all those things that adults have. So there's just a few little things that we have to consider when we have these little kiddos with us. So that's kind of how I decide to go through this PowerPoint. So we'll just touch for a brief second. I know you guys are all awesome for airway management, but that comes into play even when we start troubleshooting our alarms on our ventilator. Has our tube migrated? If our kiddo turns their head, even just from one side of the aircraft or ambulance to the other, a lot of times our airways can become dislodged. So our ventilator alarms can give us a heads up with that. If our tube is just above the cords, but technically they're still kind of intubated, you're going to see like low exhaled tidal volume alarms and stuff like that. So I like to just briefly talk about why their airways are a little bit different. Their physiologic differences, their chest wall is a little bit different. They behave a little differently. We all know kids tend to maintain their blood pressure till the very last second. So that's not a very good indicator for us for shock and how they're doing. Sean has a great lecture he just gave us at Medevac, or a little up to date on pediatric shock. And so the last thing we're going to see is blood pressure changes, but your vent can give you a lot of clues early on that things are starting to go wrong, especially if you have your alarm set appropriately and you're watching those peak inspiratory pressures rise and your plateau pressures rise. You can see you're headed down that ARDS strategy. So that's what I like to kind of set up there. We'll briefly talk about dead space. I know that there is a lot of talk about all these cool things that we can add into the circuit. I'm a little bit old school. I don't like to add a lot of stuff to the circuit. If I can make it as simple as possible. I even think our vent tubing is a little too long, especially for some of our transport vents that have like really high peak flows and stuff like that. So we'll talk about some different disease processes and ventilation strategies. I have a few, if we have time, I have a few case studies at the end, and I would love for you guys to pose any calls that you had to me and have me try and Monday morning quarterback some of your calls and see what I kind of would have done differently or anything like that. All right, so these are the three kind of big things that are different with our kiddos versus our adults. Our airways are positioned differently. Their airways are, like I said, positioned differently. Their tissues are a little bit different in their airway, a little more floppy, a little less cartilage than we're used to. Chest wall, same thing. Their lungs are made to be protected by their rib cage, but we know that there's more cartilage in their rib cages when they're younger. So that's why we see more pulmonary contusions, less rib fractures with our kiddos because of their chest wall issues. Smooth muscle innervation, that has to happen. So this is how our kids technically grow out of being an asthmatic. So my kiddo is one of these. So he technically has RAD, and the older he gets, the better it gets. And that has to do with that smooth muscle innervation and how that smooth muscle tends to structure around his airways the older he gets. And they get less and less reactive, less and less floppy, things like that. So that's something we see as well. So just that quick picture about how an airway is different in a kid. The big thing I think for all of us when we go to intubate these kids is just their big occiput that just tends to push their airway forward and just gives us a really bad anatomical position. So easy way to fix that is just our towel rolls underneath their shoulders, just to give us that really good sniffing position. Infants are obligate nose breathers. So this is really important when we talk about other ways of ventilation. So when we start talking about non-invasive ventilation and our high flow nasal cannula and things like that. That's why those things can be really effective for our kiddos, that we put a lot of flow up through their nose. It causes some back pressure, and that causes basically PEEP in their airways. And then we can give nasal CPAP to our kiddos that way. So we implemented that at our agency just with a high flow nasal cannula with our RAM cannulas, and we're having a lot of good success with that. We're not having to put a lot of our kids on BiPAP just to get them from one place to the other. We're able to keep them comfortable on a high flow nasal cannula. So We run into some issues with that in transport, obviously, because those normally in the hospital can go up to very high flows. And just like you're limited, like we are, we're limited with that 15 liter per minute flow, maybe up to 20 if you flush it. But so our adults, when we do that, we can't really give them the flows that they need to give really good high flow nasal cannula. We can get up to 15 liters per minute, and that's a lot through their nose, but we're having a really good success with this in our kiddos. So if you have any questions, feel free to email me. I'll share our little setup with you that we're using and things like that. So that bigger tongue, that will bite you a couple different ways. It's easy for them to occlude their airway. So if we give them a lot of medicine that tends to relax their muscles, that's why we tend to not sedate our kiddos too much. A little bit of pain medicine does them a lot of good and gives us kind of those both sedation and pain. They respond really well to that. And then we have a lot of problems with our kiddos who have structural problems. So our Down syndrome kids who have really large tongues in the first place, if we have cleft palates and all those structural abnormalities, that's always a problem as well. So overcoming that initial, you stick your laryngoscope in there and you can't see anything. All you can see is that tongue enveloping your whole laryngoscope. So that's never real great. The cartilage, that is different from our adults versus our airways, our adults versus our kiddos. They're cricoid, so that's sometimes where we fall into a lot of problems where people can't pass that tube past their cricoid cartilage. And then right below that is that their airway is more funnel shaped. It's not the same size as when they're an adult. So that tube gets even smaller. So if you've aggressively picked a bigger tube size, you may get it right past that cricoid cartilage, but then you can't advance that balloon any farther below, and then you end up having to redo the intubation all over again. So that's always kind of a problem. Everything is kind of a little more superior and anterior in their whole airway. That's just a better way to think about that. And then their epiglottis is just a big old pain in the butt, huge in their airway, always in your way. The minute you touch that, that thing just goes crazy, whether they have epiglottitis or not. It's just a really sensitive piece of tissue on all these kids. So our kids rely a lot more on their diaphragm. So that's an easy way to tell how exacerbated our kids are early on. I tell a lot of the people that I teach that when you start looking at retractions and belly breathing and stuff like that, I can get a good gauge on how these kids look based on what kind of retractions that they have. You know, so if you have some intercostal retractions way down low, you know, that 8 through 10 kind of rib area, that's like an early on type of scenario. When that starts to kind of ascend upward, and now we have global retractions all through their rib cage, we're starting to have suprasternal pulling. And then when we start to have tracheal tugging, as that starts to go up, when I see issues with their trachea, they've been compensating for a long time now that their retractions look like that. Or in another scenario, if they had like a aspiration or if they have a foreign body obstruction, that kind of retractions will happen immediately depending on what kind of disease process they have. But if you go on an RSV and you look and they're retracting all through their chest, you can see, you know, that suprasternal, you can see that tracheal tugging, and then you see that discordant breathing, you know, with their belly pulling high and their chest sinking in. That whole discordant breathing, that kiddo's been working a long time and is working really hard. And you know as well as I do, we don't know how long that kiddo is going to be able to maintain. We have a better idea with our adults that they can't maintain that very long. Sometimes our kids are so resilient, we just never know how long they're going to be able to do that. So those kind of structural problems are a way that I use for my physical assessment and my kids to let you know. Same thing, and we'll talk about when we talk about asthma, some different ways in their exacerbation that I can tell how bad they are, kind of how fast they're advancing through all those stages of their asthma attack. So just another picture of how things are positioned a little bit different on our adults and our kiddos. Not really anything we're not used to seeing. All right, so those big pediatric bad airways, these are just a few of the things that I've encountered that I've had problems intubating. There's And then always is that crash airway with vomiting and stuff like that. There's tons of good salad videos out there. And then really fun practicing with those, as long as someone doesn't pick really something disgusting that comes out of that airway. It's bad enough we have to deal with that at work. I don't want to deal with that when we're training. But those are really fun clinical scenarios to go through to try and get that airway when someone's vomiting. But these are some of the structural problems that I've ran into that immediately, even in the OR when I try to intubate these kiddos, you have problems with. So that Pierre-Robin syndrome, that's just that really small lower face structure. Their tongues are bigger, everything's displaced. A lot of times you couldn't even get like a zero blade, or that zero blade was like cutting into both sides of their mouth, depending on how old these kiddos were. So it's really hard to get a laryngoscope in that kid's mouth. Your Down syndrome has to do with those kids, their tongue and the structure of their face is a little bit off. Another thing interesting about Down syndrome kids is they're hypermetabolic. So your RSI meds are not going to last as long as you think they are. And definitely your sedation and your paralytics, your VEC and ROC and stuff like that are not going to last as long on these kiddos. So to be well prepared for these Down syndrome kids. They're hypermetabolic, they emerge really quickly. So that's something I think about. And depending on your degree of like your cleft palates, sometimes that can be really hard. And then keeping that tube in place when you have a cleft palate is so hard. So I always like to use the Neo bar when I did that, because it kind of displaced it off the top of their palate, you know, because they always have like a groove or even a hole in the top of their palate. So that tube can get wedged up in there and extubate these kids really easily. So I like the Neo bar. It lets it hover right in the middle of their mouth. And you can Google that if that's something you're interested for your agency. And then any of your kiddos, just like your adults, if you look at an adult and he has an old tracheostomy scar and scarring all over his neck, you're like, whoa, what happened to this dude? What has he been into? You already are kind of assessing that airway has damage. Same thing is going to happen with these preemies. So these babies that are born at 23, 24 weeks, they're intubated for several months at a time. They have tracheal stenosis, all stenosis in different parts of their airways. Their lungs are scarred because of their surfactant deficiencies early on. So they're just sometimes kind of a nightmare to deal with. Hopefully, I would rather them have some structural problems and be able to ventilate well, because honestly, they have some pretty serious lung damage and they're hard to ventilate a lot of times. So these are just some pictures of those. So these are these Pierre-Robin kids, and you can see they just have that lower mandible that's basically non-existent. A lot of them have cleft palates with that as well. So just a whole group of abnormalities that goes on with these kids. These are like our Down syndrome kids. So you can see when you look at that and try and develop a Mallampati score for that kiddo, and you put a laryngoscope in that kid's mouth, that tongue is just going to swallow it. And then these are just some pictures of some cleft palates. So you can see that groove in the top of their airway is a perfect spot for your ET tube to migrate into. And then the minute he turns his head, that thing will be right above the cords, and then you'll be extubated. So, and then just these little micro preemies you can barely get a zero in their mouth. You're intubating them with a 2.5 tube. So they're just kind of a little bit of a mess and stressful to kind of intubate. All right, so we talked about their airway issues, all the stuff from the top when you stick that laryngoscope in their mouth and try and get that tube in there. Something else to think about is their chest wall differences. So the one good thing is that, when I ventilate adults now, a lot of times I'm having to deal with their body habitus, so when they lay down and then you RSI them and you knock out all that kind of smooth muscle innervation, that tummy and diaphragm relax. That's how we get vomit in their airways a lot of time, is when that diaphragm relaxes and lets that stomach contents come out. And then with kiddos, it's kind of nice because you don't have those huge tummies pushing in on things like that. And they tend to have very compliant chest walls. So I hear a lot when I teach people, like, oh, I don't want to put too much PEEP in there. I don't want to blow up their chest. that's not really, kids don't have a more sensitive lungs or sensitive chest really than an adult does. And they should be more compliant and easier to bag, depending on why you had to intubate them. If that was a structural issue, you know, if they hit their head, something like that. But if they have lung disease, that's a different story. But think about their chest wall and all the cartilage in there. You shouldn't have to be trying to push through a really defiant bone structure. So it should be a lot easier. One thing I like about this picture is it shows where their trachea sits inside of there. So when you're looking at tube depth and things like that on an x-ray, your tubes are going to be a whole lot higher than your adults when you start looking at where your tube's supposed to be on your chest x-rays. And then the picture next to it lets you see kind of the shape of their chest. So, you know, they have a little bit of these narrow barrel chests in the beginning. And then as bone structure grows and muscle structure grows, the actual circumference and the shape of their chest tends to be a little bit different. But that, you know, that comes into play too when we start thinking about pulmonary contusions versus we shouldn't be seeing rib fractures in these kiddos. The amount of force that has to be exerted to give a kid a rib fracture is tremendous. But what happens then is that our kiddos are more susceptible to pulmonary contusions and bruising of their lungs and things like that. So this is just that normal picture of what happens when you breathe in, that diaphragm pulls down, you get that negative inspiratory force. So think about, I try and remind people every time we ventilate somebody, think about that we're automatically doing opposite of what the body is used to. So trying to manipulate your ventilator or your ventilation with your BVM is really important because this is already a foreign act in the body. We're doing something very opposite than what the body's used to. They're used to negative force. Now we're doing positive pressure ventilation. So think about those type of things when you do that. I'm sorry, this picture turned out not very awesome. One thing I like to say when we talk about our asthmatic airways, think about that every time someone has an asthma attack, there's 3 different things going on. And you can see number 1 is that tightening or that stricture or that smooth muscle around your airway. So it tends to just narrow the diameter of those airways. Then you have this internal swelling that's happening. And because of that inflammatory cascade, you have mucus that's happening. So you have 3 different things that are happening. So this is how I like to remind people, yes, albuterol is helpful, but you have 3 things happening. So one therapy or one drug is not going to fix this necessarily all the time, especially if we're headed toward intubation and ventilation with this type of patient. So our asthmatics should have that multifaceted approach. So yeah, they're going to need bronchodilators and they're going to need a lot of them, but they're also going to need steroids. They're also going to need MAG. They're also going to need terbutaline, depending on what your protocols are, to get those things loosened up pretty quickly. And then now I like to remind people, how long do our steroids take? You know, at least 20 to 30 minutes. What can we do immediately right on scene to fix this inner diameter swelling? And that's PEEP. So however you're going to deliver that, your high flow nasal cannula, your CPAP, your BiPAP, any of your non-invasive ventilation modes is how you're going to overcome that internal swelling. And until that albuterol and those steroids have time to really set in and kick in for you, your only mode that's going to fix that for you is CPAP and BiPAP and non-invasive ventilation. So this is one of the things I really love talking about and teaching, because I think we can really help our asthmatics early on if we start instituting CPAP and BiPAP early on.
Hey, Melissa, I just wanted to pop in. I have a question for you about that, because I remember early on, one of the things that was taught is that, you know, that these positive pressures, non-invasive positive pressure, was dangerous for these asthmatics, right? And that was kind of in the early days of BiPAP and CPAP being added to, you know, the 911 ambulances, you know, back before my days of critical care. So I don't know if that's something still being shared across the country as far as giving, you know, CPAP or BiPAP to asthmatics because of, you know, air trapping. Do you have any comments on that?
Yeah, so that is still definitely around, and where I see it a lot of times are people that are not confident, that are not commonly treating kids. So where I don't see it is when I go into PICUs and things like that. It's used really early on in the pediatric ICU setting, and people, especially adult caregivers, and I see it a lot in the EDs. I've heard from so many ED docs when I've come in with an asthmatic on CPAP, on a continuous neb, they had an IV, they had Solumedrol, they had a fluid bolus, and I hear, oh my God, you put them on positive pressure. And I think that what you hear is that asthmatics auto-PEEP. And they do, but they don't always auto-PEEP until later on in their exacerbation. So if you come on to this call and you're early on, then you have a chance to turn these kiddos around before they get really bad. Eventually, when they've created so much dead space ventilation and they're harboring so much pressure in their chest, they do have auto-PEEP. But that is very late on in their exacerbations where they're nearing respiratory failure. So I think that I'm going to venture to guess, and this is not even any sort of scientific thing, I think our kiddos are doing a whole lot better, and I see a whole lot of easier to control asthma exacerbations because of how good our asthma care is now. You know, you go into you take your kids in there and they get diagnosed with RID, they immediately get sent to a pulmonologist, they go home on different controlling medications and stuff like that. So I don't think we're having those huge asthma attacks like we used to. So that's what I think. I have never been chastised or anything like that when I've brought in an asthmatic to a pediatric center, but I have caught some heat from some EDs and things like that. So I think that's a very often talked about topic. And yes, you're right. So if you have a crashing asthmatic that you have to intubate and you're trying to bag them and their airway pressures are easily in the 50s, 60s, 70s, that patient has auto-PEEP. At that point, you're going to do whatever you can to ventilate that patient. You probably are going to have to add a little bit of PEEP because there's so much PEEP in their chest. How are you going to push anything in? But at that point is when you're going to start talking about, maybe I'm not going to have any more than 5 on there. Maybe I'm only going to have 5. I'm not going to go above 10, those things like that. And then when you have that asthmatic that is crashing and you can't get sats up, you can't bag it all, your vent absolutely will not deliver any tidal volume to that patient. And you start having vital sign changes, bradycardia, things like that, arrhythmias, that's that time to pop the patient off the vent and do kind of that external squeeze and force that PEEP out. I've had to do that twice since I started. I've been an EMT since 1998, and then I've been an RT since 2004. And only twice I've seen them pop off the vent and do that external squeeze. And the kid was basically in arrest and was a really bad uncontrolled asthmatic that also had an anaphylactic reaction. So we just didn't even have time to get on top of that kiddo. But yes, we're still overcoming people being scared of PEEP for sure. That was a very long answer, sorry.
That's okay. That's okay. I think that's a great answer for people to kind of realize that, yes, it is safe to give positive pressure ventilation to these asthmatic patients and why. So thank you for finding that. Cool.
Yep. All right, so this is that when we were talking about retractions and things like that before, when you're part of like an asthma care team, different things like that. When I worked at the Children's Hospital, you score these asthmatics. How bad are they? One of the things you score them on are how bad are their retractions. So this is kind of a easy chart to kind of look at and see. So, so early on you have that synchronized breathing. You kind of have that lag when it starts to get worse. And then here's that belly breathing and that discordant breathing that we talked about. Early on, no retractions. Here's these intercostal retractions. And then later signs, you're going to see retractions posterior and anterior. Same thing, retractions visible. Here's that substernal. Here's the suprasternal up here. And then here's where over here, when we start talking about chin movement, when you see a kid physically moving their head and moving their chest, that is really last ditch effort for these kiddos. That means they have no more room in their chest. So if this is an asthma kid, you're thinking that they are very full of pressure. They're not able to exhale that pressure. So So when you start seeing them physically start to move, so their head is bobbing, and then you see those triangle muscles, those sternocleidomastoid muscles, and I'll share a video afterward, like with the show notes. That's a really good asthma attack to look at that they videotaped. I think it was in New Zealand, but that kid is one of the worst asthmatics I've ever seen videotaped. I've seen some kids like that come in to the ED, but it's hard to catch them on video. So it's a super great video, but you can see that kid's sternocleidomastoid muscles basically from his neck, and his shoulders are swinging into action, just trying to create some physical movement because his chest wall is no longer moving. So when I start seeing chin and shoulders move, I know that I am behind the 8 ball and I need to get moving, or this kid has been exacerbated for a really long time before I'm ever entering the scenario. So my threshold for sub-Q epi on these kids is super low. Kids love epi. It helps them a ton. So if I think I'm headed toward non-invasive ventilation with most of these kids, my very first drug I'll give as someone's, firing up that albuterol neb is I'm going to give some sub-Q epi early on. These kids love it. It works great. And then if you are headed toward failing non-invasive ventilation and you're thinking you're going to have to intubate this kid, get an epi drip going early on. So, and then these all have to do with that grunting and those noises that you hear from their airway, whether it's retractions or stridor or things like that. You'll see some grunting and nasal flaring early on. And then if you can hear it, but you don't hear it in here, if you hear it on your stethoscope, you're I think of these 3 phases, like here's early, middle, and late, that grade 0, 1, and 2. And then audible, that kid's pretty far exacerbated and we need to do some pretty aggressive movements there. All right, so dead space. Lots of people call this, I've heard it called the Tower of Terror. I saw a pretty funny cartoon that had like 8 feet of things added onto here. So here's what I like about this picture is that this is how we should be transporting these kiddos. And I also think we need to be transporting them with their head secured, just like we would a trauma patient, because the minute they turn their head, this tube's going to be out. So I really love this picture. I saw a couple other pictures where people tape the BVM to their chest so they always know where it is in case of an emergency, but then they secure their vent tubing on there. You don't want any tension pulling on that ET tube because it's not going to be where it needs to be. And then depending on what kind of ventilation setup, like this blue adapter right here is a flow sensor. A lot of our really good ventilators have a good flow sensor like that. You have to calibrate early on in your transport, but that's going to do some dead space. In here, they don't have, which we all transport with, is our end tidal adapter. So that's going to add some more. Then if this kid is an asthmatic, somewhere over here, maybe close to here, maybe on your inspiratory limb, you're going to have a nebulizer going. That not only is going to create dead space, then you're going to be adding flow and pressure into your circuit. So we have a lot of problems that if you have a kid that's like 4, 5, 6 kilos, and then you add in a neb at 8 liters per minute, then you're going to add in so much pressure right at the end of the vent. The vent's going to think that the patient's creating back pressure, and then your vent's going to cycle off. So something to think about, we may have to, I know in our agency, we have to lower how we give our nebs. So we're doing it at about 6 cc's or about 6 liters per minute. And then we're having to adjust our vent flow and our tidal volumes and things like that to accommodate all this extra flow and pressure in the circuit. So just remember, especially if you start, if you think you look at your kiddo and you're like, wow, I have really good tidal volume on this kid. My rate is appropriate. I have a really nice high rate. My minute ventilation, when you calculate that out or your vent does it for you, your minute ventilation is nice and high, like on these kiddos, 8 to 12 liters. And you are having air trapping and dead space and end tidal issues or blood gas issues, meaning like acidosis issues. Think about that dead space in your circuit. A lot of times you can add in your bacterial filter, your HME, your end tidal, all these things. And on a baby that only needs 50 cc's, like our 5-kilo kids and stuff like that, you've created so much dead space that their exhale tidal volume will never get back to the vent. The vent's not receiving the information that it needs. And then every time they rebreathe, they're just rebreathing their exhaled CO2 because it's all trapped in the circuit. So that can be a really big problem.
So Melissa, so just to clarify there, because you know, I've got the question, maybe other people's do. So you're saying that if you've got too much dead space in your circuit, the vent will still give you good volumes. It'll still give you good exhale tidal volumes, but that exhale tidal volume is recirculated air.
Yeah, the CO2 tends to accumulate in different places in the circuit because your flows, it's only compensating for what the vent knows should be on there, which is not anything extra. It's just the circuit, you know, and the tubing. So when you start adding that in, technically we should start increasing our inspiratory flows. And then think about when that kiddo exhales, they're only exhaling, you know, 40 or 50 cc's. That may never be making it back to the exhaled limb of the circuit. It may all be stuck in that tower of terror you've created at your ET tube. So when they take that next breath, they're not necessarily rebreathing all of it, but they're probably rebreathing some of it. And a lot of times when we take out all those filters and stuff like that, and all those things right at their ET tube, then we start seeing drastic drops in their end tidal, and then you're able to ventilate them more appropriately.
Cool. Thank you.
Yeah. So yeah, you kind of end up in a rock and a hard place because yes, you need your end tidal. Yes, you need your flow sensors, things like that. And there's times when you have to put a nebulizer in, depending on that kiddo's airway. If they are prone to mucus plugging and things like that, you may want an HME, which is your heat and moisture exchanger. Because if you're like me in the adult world, we don't get humidifiers as part of our ventilators and things like that. So our air that we're delivering is very dry. So these really young RSVers tend to not do well with that really dry, cold air that our vent is delivering. So a lot of times we'll put in these HMEs. So think about what size HME you have. There's pediatric ones, but I would urge us to even go toward our neonate ones to decrease the amount of dead space in there. We have them available to us for our adult transports, but honestly, not a whole lot of people use them. We need to be using them on our trach patients and things like that, but we haven't seen a ton of adverse reactions in our adult population. We do see it, however, in our kids. So, and one of the things I'll say, especially too about humidity, is that if you decide as an agency to start doing high flow nasal cannula, that is not something you should be doing without a significant amount of humidity. So if you decide you're going to do that and you're not going to use a commercial device that delivers humidity at that 39 degrees Celsius, like you would on the vent, you know, those really great Vapotherms, Optiflows, there's like a million names for them, a million different companies. We end up just using the humidifier bottle that you would on a nasal cannula, but you should never be putting those high flows in these kiddos' nose without humidity. I've seen a kid come in when I worked at a facility and he was transported for about 40 minutes on a high flow nasal cannula, but no humidity. And they actually did nasal CPAP through their ventilator, but they did not have a humidifier on their ventilator. And that kid was a rapid response pretty quickly after he arrived at the facility. And then when we bronched him, we pulled out a cast of his like entire left lung and most of his right lung. So they turned his secretions into concrete really early on. So make sure when we talk about kiddos and bypassing their upper airway, because that's how they humidify things, that we're adding in humidity. So that was my little tangent. You can ask Sean. I love these high flow nasal cannulas and ways to transport nasal CPAP and things like that. But I know, as well as you guys know, we're really good at just kind of rigging things together that we think will work. But we really need to do a little bit more due diligence if we're using things off label or we're not checking with our pediatric centers nearby that we all transport to, making sure that we are using the correct equipment. So I'm not going to lie, a respiratory therapist, if you give me enough little adapters and 15 and 22 millimeter adapters, I can make any circuit fit anything in the whole world. I can get as many pieces of dead space into a circuit as you want. I used to cut circuits with my jet ventilator to put nitric in there and things like that. I mean, we got crazy, but I think in the adult world, we need to be really careful when we start transporting these kiddos and start doing things that our pediatric teams do, but we don't fully use their equipment and everything that they do. So that's just my little be careful. You're not winging it here. All right, so we'll quickly go through this because we already talked about this, but this is a good picture that shows you that stricture that's kind of happening with those smooth muscles. And as you get older, your airways become a little less reactive and your smooth muscle gets a little stronger. That's why our airways tend to have a little bit more structure when you're adults versus when you're kids, and you can technically grow out of asthma, basically. My son, who's 7, gets less and less exacerbations throughout the year versus when he was 3 and we were in the ER 5 or 6 times a year with a really bad asthma exacerbation. So I'm watching that live happening at my house every day. So these are all those things, just like I talked about. This needs to be your multifaceted approach when you come across this kiddo. So remember that we're going to walk in, we're going to look at them. How are they breathing? How hard are they breathing? Are they using accessory muscles? Can you hear airway noises? Can you hear inspiratory and expiratory wheezing? Can you hear stridor? Remember that wheezing is lower airway, stridor is upper airway. So can we hear things when we walk in? How is this kid's mentation? So even before you touch that kiddo, you can have a pretty good idea of what's happening here. If that kid's limp in the mom's arms, or an agency got there before and they're starting IV and that kid's not crying, we're in a bad spot already. So this is kind of what we do. We're going to walk in, we're going to give our bronchodilators, we're going to give our non-invasive ventilation, we're going to load them up with all those good drugs, our epi, if we have upper airway issues, our racemic epi. We're going to give whatever you have, Solumedrol, if you're going to give MAG or TURB, any of those things that has to do with your specific protocols or whatever children's hospital you guys are affiliated with, they prefer. It kind of switches back and forth all the time here in Colorado, what they prefer. Sometimes it's easier just to give TURB versus MAG, whatever, just get something on board quickly and get that non-invasive ventilation going early on. So these are just those quick signs and symptoms. I'm guessing this is not going to work, Sean, unless you want to try and see it. This is that asthma exacerbation kid that.
What are you talking about? Are you talking about the link?
Yeah, and if not, maybe we can just email it out afterward for people to look at. It's a great YouTube video if you look at asthma exacerbation. I'm pretty sure it's from New Zealand. But it's a super great way to assess a kid early on when you're looking at them and they're doing everything right. Minus, it's kind of old, so you're not seeing the non-invasive ventilation. I would have put this kid on BiPAP really early on, which you're not seeing. They're making him kind of weather this out. But
yeah, give me just, I'll see if I can pull it up.
Okay. You can see all those things. Early on, the first thing those kiddos are going to do is increase their respiratory rate. So they're going to get tachypnic. They're going to start nasal flaring. Those are early on. Their chest is going to get tight. A lot of asthmatics will just start coughing. That's something my son does, is just kind of go into a pretty big coughing fit. Obviously, most of these are all late signs. If you're seeing color change in your kiddos, that's a hemodynamically unstable kid. You don't need a blood pressure to tell you that kid is in super, super big danger if your kid is cyanotic. So anxiety is a good way to tell if your CPAP and your BiPAP are working. If it's been on for 10 minutes and your kid's getting more and more anxious and ripping that mask off, either you don't have aggressive enough settings or that kid's just progressing and we need to start thinking about intubation. Tachycardia is early on, I think, happens with tachypnea. We don't see diaphoresis a ton in our kids, and then this level of consciousness is always a bad sign. You think you'll be able to pull it up?
Yeah, give me 1 second. Let me see.
Okay.
Almost there, guys.
Yeah, if not, we can email it out afterward too, so.
We'll do that anyways. We'll add this in to a post over at the website and email a link out to everybody for them to take a look at.
Okay. Do you want me to keep going?
Are you seeing the YouTube page right now?
No.
You're seeing your PowerPoint.
Yeah.
Let's see here. Yeah, you can keep going, and I'll let you know if I get this up. Cool.
All right. So for our treatment for asthmatics, I've been talking about it over and over and over again. This is one of my favorite things to talk about. Is immediately whatever's triggering them. So if they're in a house where family members are smoking, get them outside. If they're outside and they're like my son, who's allergic to every tree, grass, bush, everything that is in Colorado, try and decrease that for them as well. Obviously, whatever your local protocols are, if you're going to give 3 back-to-back Combinebs or albuterol and Atrovent, sometimes agencies will give only 1 dose of Atrovent. Whatever is part of your protocol, make sure to do that. This is just what I think about and is what is my workflow, basically. So I'm going to walk in, I'm going to make sure that if something is in their house or in their environment, I'm going to get them out into the ambulance to discontinue that. Someone's going to be getting a neb going. We're going to be starting an IV to give Solumedrol or MAG and then if you're going to give sub-Q epi or TURB, those things you don't need an IV for. And then I'll be hooking up non-invasive ventilation pretty quickly. And then make sure that we're heading toward definitive care because no one wants to intubate an asthmatic and deal with them. It's one of the hardest things to bag. So make sure that we're quickly headed toward the hospital at that point. All right, so here's what I think about when I start talking about, all right, well, we did all those things and your kid has decreasing level of consciousness. Your end title is now saying, this kid is, 80 or 90 on their CO2. And remember too, if you have access to blood gases, that is one of the things that I preach pretty big, especially in the critical care world, is that end title is great, except for when it's not. So if you have a big VQ mismatch, and so think about that, the vent is delivering oxygen and it's ready. And so you are just ventilating that top third of their lungs because their body is bringing back CO2 and dumping it in at that alveolar capillary membrane, which is the lower third. Well, what's happening in that middle third is all that auto PEEP and things like that. So you're dumping in good ventilation from the top, their body's returning good CO2, but there's no communication in that middle area of their lungs. That's basically what happens is that pressure just starts to build. Those middle airways, those lower airways collapse and trap air below them. So you have to splint that airway open, and that's that CPAP and BiPAP in order to get that top and bottom layer of their lungs to start communicating. So a lot of times what you'll see is an end tidal that's low, because think about that end tidal that your body's dumping in to your lungs is not getting up to the point where it can be exhaled out and your end tidal can read it. So a lot of times you'll see low end tidal exhaled CO2s, but you're like, this kid looks like garbage. What is going on? If you have access to a venous blood gas, that's fine, or a blood gas, or if you're in a facility to have them pull that before you go, because I will not use an end tidal to guide my treatment unless I am sure that it correlates with an ABG. So plenty of times I've seen really good end tidal CO2s like 30s and 40s. I've pulled a blood gas and their CO2s are 80s or 90s. We had a team recently in the area where we worked. The kid looked worse and worse and worse. They weren't having end tidal changes. The kid ended up respiratory arresting. When they got to the hospital, they pulled a blood gas. He was 6.91 and a CO2 of 130. So that is a severe VQ mismatch. So that is just something I try and urge to people. End tidal is an awesome tool, especially with our cardiac arrests and things like that. And we're trying to evaluate shock and things like that. Where we start having really big issues is our respiratory patients. And if we're using that to guide treatment without correlating it with an ABG. Even when I've listened to end tidal reps, they very briefly do a quick thing like, oh, it's really great, unless you have a VQ mismatch. And then they move on because they want to highlight how great it is. And it's great, except for when you have a VQ mismatch. And think about, that's exactly what an asthma attack is. That's exactly what ARDS is. Your drowning patients have a VQ mismatch because of the fluid in their lungs. Your chemical pneumonitis patients, so a kid that eats a Tide Pod, that is a mechanical VQ mismatch. That Tide is preventing you from pushing in oxygen, preventing their body from exhaling CO2. So all those things are happening. So I don't use, end of this rant is that I only use end tidal once I know it's correlated. So, all right, sorry, that was way too passionate about my end tidal issues. So here's what I think about when I think about ventilation strategies. I've tried everything I can non-invasively, very aggressive non-invasive strategies. My kid's losing consciousness, is getting more anxious, is not keeping that BiPAP on. I'm gonna have to go down that ET tube route. And I'm very lucky that I have access to RSI, because if not, you're in a rock and a hard place to try and ventilate this kind of kiddo. If you're just gonna try and BVM ventilate this kid. And so make sure, a couple things that I like to talk about is that if you're going to choose to ventilate this kid with a bag valve mask or with a pediatric anesthesia bag, I love the anesthesia bags. And we'll attach some videos with that if that's something your agency is thinking about. But just a great way to ventilate your kids. You're able to monitor and give certain amount of peak inspiratory pressure, so that pressure, that force on the squeeze. So think about that. I just listened to a podcast with Scott Weingard where he was talking about that BVM, and he says when they monitor it in their trauma center, that easily those initial squeezes that whoever is bagging, you're easily over 70, and he says he commonly sees peak inspiratory pressures over 100 on a BVM. So number one, you have an asthmatic kid. Hopefully you have a pediatric or a infant BVM, because we're seeing more and more that we're just over ventilating these patients. Adult or kids, doesn't matter. A lot of places, even with their adult patients now, are using pediatric BVMs, because we are realizing you don't need more than 500. You just need a good respiratory rate, not a fast one, a good one to maintain that good minute ventilation. Minute ventilation is your respiratory rate times your tidal volume. Normal adults is 5 and above. The sicker you are, you need to be that 5 to 8 range. Closer to 8, the sicker you are, and our kiddos should be 8 to 12. So if they're intubated for a head injury, they don't have lung issues, you're fine with a minute ventilation toward 8. You're intubating because they're a respiratory failure post-drowning, you should be in those double digits. That 10 to 12 kind of area is what I think and what I commonly see. So, all right, so we start bagging this kid early on. I'm not gonna be able to pick if you see your tidal volume over there. So I'm not sure, I know it differs in different places. You guys are, I think, all in different states. But even I just read a ventilation book from someone that was out of state, that was over near, I think, Minnesota. And they're still using commonly 8 cc's per kilo. And then when you have a sick patient and you're looking at those ARDS, those ARDSNet protocol settings, you're looking at that 4 to 6 cc's per kilo. So I tell my team when we're picking, make sure adults, kids, everybody, if they have good lungs, they're 8 cc's per kilo. Bad lungs, 6 cc's per kilo. And then you can even settle for 4 cc's per kilo, but you're gonna have a pretty aggressive respiratory rate as well as a good amount of PEEP to overcome the amount of atelectasis and lack of ventilation and pressure that you're giving that person or that kid in their chest. So think about as you bag that kid, you want nice, easy squeezes. If that's all you have access to is a BVM, that's fine. We can still effectively ventilate our kids with a BVM. We just need to do it in a smart way. So never using adult BVMs on these kids, never forcing. So you're already gonna meet resistance if you're intubating an asthmatic. So make sure you're not forcing ventilation, and you may have to do a faster rate with very tiny tidal volumes until all those drugs that you pushed in start kicking in for you. But if you're pulling up your vent and you're like, all right, here we go, we're gonna just start ventilating this asthmatic, like the nightmare of a call that we all go on, I'm going to start with 6 cc's per kilo. I'm going to start trying to ventilate my kiddo at 6 cc's per kilo if I know they have sick lungs. So depending on what kind of vent you have, whether it's a volume ventilator or a pressure ventilator, either one, we'll talk in generalities here. And then if you guys have questions specifically about the vent that you have, feel free to email me, or we can talk about it at the end of this webinar, and I can try and troubleshoot some issues for you, no problem. So my vent that I use is a volume and a pressure ventilator. I can choose what I want to do with them. There's a lot of new vents out there that have really, really great modes. So just let me know what kind of vent you have. So I'm going to immediately start picking a tidal volume around 6 cc's per kilo. And I'm going to see in volume ventilation, if I can volume ventilate this kid, what kind of peak inspiratory pressures I'm getting. Most likely they're going to be really high. So if I'm starting to get uncomfortable, and here's the thing, so if you have a peak inspiratory alarm set at 40, or if you are brave enough to go up to 50, most likely you're going to hit that early on, and your vent is going to cycle into exhalation. So you're not delivering the tidal volume in the minute ventilation you think you are, because when that vent hits that peak inspiratory alarm, it's going to cycle off. Or if you're in a mode like APRV or something like that, it's going to vent off all that extra pressure, and you're not delivering what you're trying to. So you're going to need, if you're in a volume ventilation mode, just go up and look at your peak inspiratory pressures and your exhaled tidal volumes. Are you trying to, push in 100 cc's on this kid and you're only able to get in 20 before the vent high pressures and cycles into exhalation? That's going to be a problem. Immediately, you can try and dump your tidal volume down even into the 4 cc per kilo range. But most likely, we're going to end up in pressure control really quickly on these kids. So think about that when you decide that you're going to bail from volume ventilation and go to pressure control ventilation, because here's where I see people fail, is that think about you had your high pressure alarm set at 40, and your vent was not able to deliver the tidal volume wanted at 40. So when you switch into a pressure control mode, think about that as that inspiratory pressure or that pressure control setting. So on my vent, it's not PEEP compensated. So if I am deciding that I'm going to try and push in 40 centimeters of water pressure into this kiddo to see what kind of tidal volume I can get, and then I'm going to use 5 a PEEP. On my vent, I have to dial in 35 for my pressure control and then 5 a PEEP. But here's what I see. I see a lot of people flip that over and they're like, well, I don't want above 30. So, I'm going to put 30 over 5 or 25 over 5. You're not going to be getting tidal volumes. Your kid's going to automatically, their intitles are going to start skyrocketing. So I see people not pick aggressive enough pressure control settings. So a good thing to think about is, where was your pressure control or where was your peak inspiratory alarm set at? Hopefully you didn't have it set above 50, because we don't want to maintain those kind of pressures. But if you had it set at 40 and your vent was popping off at 40, that is a good place to start for your pressure control setting. And then you need to go up quickly and start looking at your exhale tidal volumes and say, is this working? Is this mode of ventilation working for this kiddo? Am I getting 4 to 6 cc's exhaled tidal volume on this kid? Because that's the way to determine and guide your pressure control settings, is your exhaled tidal volumes and things like that. So remember, these kids, especially if you're allowing those low tidal volumes, you need to compensate for a rate with your rate. And then we'll talk about asthma is a little bit different than ARDS, because a lot of people are thinking, oh, right now she's starting to talk about those ARDSNet protocol settings. The problem is that you're not going to have extraordinarily high PEEP on this type of kid. If you have a true ARDS kid, you will, and that's that multifaceted approach. So you're going to decrease your tidal volume, you're going to increase your rate, and you're going to increase your PEEP if you are going to do ARDSNet protocol. But that's not what we do on asthmatics, because they have auto PEEP issues if we're ventilating them at this point. So you want a little bit of PEEP, not excessive levels of PEEP. So remember that. Early on, if you decide to try and go up on your PEEP, this is what they call, so you're giving external PEEP, and then they have internal PEEP. So if you have that dead space ventilation early on, I commonly see RTs and PICU docs and stuff like that try and give a little bit extra pressure early on and see if we can kind of overcome that dead space in the middle. And then hopefully your external PEEP pops open those airways and stents open those closed shut airways. And then your auto PEEP, everything that's stuck below, can start to vent out. So that's that strategy that we hear about that really freak people out sometimes. It is not going to work on everybody. It's not going to work if they have humongous amounts of auto PEEP and are near arrest. This is early on in your ventilation when you're trying to prevent that inevitable chest filling with PEEP craziness. And this is going to be a setting that we probably don't keep on very long. You're going to know pretty early on if your kiddo tolerates this or not. So what you should see is that initially your end titles, whatever they're going to be, if this works, you should have an early increase in your end tidal. Because think about that. Now you've opened up those closed airways, and now all that trapped CO2 is going to start coming out. So you should see a sharp increase in your CO2, your end tidal CO2, early on, and then it should start to come down. It shouldn't stay up. If that happens, we have different issues going on, more respiratory failure issues. So I know that's a lot to talk about, and it's unfortunately, even when we talk about ventilation, adults or peds, there's no hard and fast rules. It's awesome with drugs. You know, you're going to give 0.1 per kilo of this drug. It's not like that with ventilation. And you'll see that whatever facility you work at, or if you go do clinicals at different places, every doctor you work with from shift to shift to shift are going to have different ventilation strategies. And honestly, you're going to meet RTs and paramedics who are really awesome with the vent, who are going to have different strategies than me. This is just what I've used and what has worked for me. So I'm going to try early on and see if I can do a little bit extra PEEP and see if I can open up those airways and start to release that. If that doesn't work for me, I'm going to drop my PEEP back down. I'm going to do my low tidal volume strategies with my pressure control settings. I'm going to be shooting for 4 to 6 cc's of exhaled tidal volume. My rates are going to be really high. And remember, you're going to have to start adjusting your I time. So these are a restrictive process. So we're looking for IDEs of 1 to 4 easily. And the way to manipulate that quickly is your I time and then eventually your respiratory rate. But these kiddos are going to need a fast I time so they have longer in their expiratory phase, longer to exhale that CO2 out. So make sure whatever, if you pick infant, pediatric, adult mode, whatever you pick for these kids, make sure you're adjusting their I time to give you an optimal I to E ratio. And then your permissive hypercapnia. With these asthmatics, easily their CO2 is over 100 by the time they're in ventilatory failure. So getting from 100 down into 40 for your ideal end tidal or your ideal CO2 on your blood gas, that's a humongous swing, and it's not what we need to be doing, especially on transport. So permissive hypercapnia. We know that them hanging out in the 60s is not going to do tons of damage to them, but over-ventilating them and being crazy about that stuff will do a lot of problems for them. So any questions? That was like a ton of information before we move on to some different things. Any questions about asthmatic ventilation?
You guys should be able to see a button at the top of the screen. It's kind of like a hand raising option, or you can just type your questions into the class conversation bit. If you do want to speak, I can always try to turn on your camera and microphone. Give it just a couple minutes for anybody to type in a question.
Yeah. So
I think that's all really great information because, you know, Melissa, thank you for that, because we know that these asthmatics are terrible to ventilate. You know, last thing we want to do is, but when we do, we need to be very wise in how we ventilate them after the tube is placed. I'm not seeing any questions pop up, so
okay.
We'll move on. If you guys have anything that pops up, feel free to just put them in the conversation and we'll address them.
Yeah. So, and the next slide just kind of talks about, all right, so you intubated this kid and you ventilated the crap out of him on the way in and you did an awesome job and you get to the hospital. And what are they going to do when they get there? They're going to try, their vents have a lot more options than our vents do, fortunately and unfortunately for us. So this is kind of that top row is kind of what we're doing. We're, initially trying our non-invasive ventilation, aggressive with our meds and things like that. We're extending their exhalation phase. We're going to have to increase their peak inspiratory pressure. That's why we end up in pressure control ventilation most of the time. In order to exhale all that CO2, we're going to allow for some permissive hypercapnia. So then they're going to go to the PICU or the ICU, wherever they are. And what's going to happen after that? So they're going to mess with their PEEP. They're going to paralyze that patient because they don't want them participating anymore. Their body's failing. They don't need any help from them. And they're going to try some different things. So there's this over here is just kind of some of the things I've seen tried. We don't really use bi-level in kids, but it's basically a high PEEP and a low PEEP, and they can breathe in between. But APRV is a mode that we're seeing a lot of. And then if you need effective removal of CO2, you're going to go to a high frequency ventilator early on. And then if you have a lot of hypoxic issues and then you have pulmonary hypertension as a result of your lungs being hypoxic and hypercapnic for so long, you may end up with pulmonary hypertension, and they're going to think about adding in some of that nitric oxide. If they do all this and your kid is popping pneumos and going down the tube, that kid is going to end up on ECMO. Very rarely I've seen that, but honestly, when an asthmatic ends up on ECMO, it just means their lungs have taken such an insult. It's not great, but that is kind of always your flow. So you do the best that you can. When they get into the hospital, they're going to use some of their really awesome modes and some different kinds of ventilators, like that high frequency ventilator. They have access to different gases, like that we don't have normally on adult transport, especially on NICU transport, you do. And then ultimately, if their lungs cannot function anymore, they're going to go on bypass, on ECMO, on VV ECMO. So think about that. No matter what you do, sometimes you're not going to be able to recover these kiddos like that. So the next one we see a lot is our RSV and our bronchiolitis. Fortunately, these kiddos don't get intubated a ton, especially if you're at a place that does aggressive pulmonary toilet or aggressive suctioning on these kids. Honestly, that's just what they need. They need help. It's a normal response to like a cold that you and I would get, but it's so much secretion, so many secretions for these kids. They just can't handle it. It fills their airways. It causes the inner diameter of their airways to become smaller just from the amount of mucus in there. Depending on what kind of kid that is, it can cause bronchospasm and things like that, depending on if they're an RAD or a reactive airway disease kid. So things like, normally we don't need that. Normally they need a little bit of oxygen. A lot of times these are those high flow nasal cannula kids or those Vapotherm or Optiflow, whatever your facility has. That works really great on these kids. A little bit of PEEP pushes those airways open and allows them and you to start clearing those secretions, but keeps those airways nice and open. When those airways start to get floppy and collapse, then they really have problems managing those secretions. So one way that can make these kiddos worse, so when I've been a part of places that have an RSV or bronchiolitis protocol, albuterol is not a part of it. So think about that. That's going to be a smooth muscle relaxer. So sometimes that will relax that airway and cause that airway to just become really floppy and kind of squish in on itself. So a lot of times you'll give an albuterol and this kiddo will retract like crazy and look way worse afterward. Sometimes they're an RSV kid that has RAD too, so you have to walk that line. But in general, albuterol is not going to help. This is a secretion problem. So you just need to help them clear their secretions and maintain an open airway. So your high flow nasal cannula, your CPAP, your BiPAP on these kiddos, and then aggressive airway clearance is great. I've walked in a kid that looks like a little bit like this kid, very pale, very cool, clammy hands and feet, a little bit of cyanosis. He is breathing and retracting like a crazy person. And all I did was walk in, pull out a nasal cannula that had no humidity on it, I spent about 10 minutes aggressively suctioning and lavaging his airway. And then he was transported on 1 liter high flow nasal cannula with humidity, awake, alert, and oriented, where they were pulling in the code cart, getting ready to intubate this kid. So no joke, it is literally just a secretion problem. So don't be afraid to get in there and get aggressive in the back of the ambulance. There's lots of different kinds of suction. There's that mushroom tip suction. That's fine. But if that kid is casting and just concreting his whole airway, you need to do a nasal tracheal suctioning. So you need to pass that suction catheter through their nose, down the back of their oral pharynx, into their airway, and suction out that airway. So I know it's not great, but just papoose these kids, hold them down, and get crazy with their airways, because you'll be able to make them feel so much better really quickly. So these kiddos, it's all really that lower respiratory virus. You shouldn't be hearing inspiratory stridor. You may hear wheezing depending on what's going on. Most of the time it's rhonchi and rales, and then they're just really working really hard to breathe. That chest and belly just kind of coordinate breathing that happens. So that's kind of what happens there. What happened? There we go. So like I said, it's just all aggressive suctioning. If you happen to have an RSV kid that's on the ventilator, just be aware it's a secretion problem. Those secretions are going to start to move, so you're going to have to suction that kid's ET tube pretty frequently. So for us, I urge everybody, if you can, to have an inline suction catheter. Remember, every time you pop off that ventilator circuit or your BVM, your bag, or your anesthesia bag, you're de-recruiting everything you've done. So you'll lose all your PEEP and all that good ventilation that you did. You're exposing that baby to more infection, and now you've just exposed yourself to whatever that kiddo has. So there's multiple things that are happening there. So if you can not pop off your vent circuits and things like that, we use Ballard, so inline suction catheters, so we can suction inline and not have to pop them off our ventilator. But they're most likely going to need a lot of suctioning on the way down. You may even have to add a little bit of saline. I'm talking like a couple little drops down that ET tube to make sure that their ET tube doesn't plug off. I have seen that before. Your trach kiddos, if they get RSV, that trach can plug off really quickly. So if that's the scenario you're in, make sure, number one, you take that kid's extra trach. If you go in and pick up this kid at home, home care and that mom and dad probably have that kid dialed in. So there should always, with a trach kid, be an emergency trach at the bedside to be able to change out really quickly. And then ask your mom and dad that's taking care of those kids, how are you suctioning? What are you getting out? Are you able to pass the catheter as far as you normally do? But be ready to switch out that trach, because it can plug off really quickly. So make sure you're comfortable doing that, and you have an extra one size smaller trach to put in an emergency situation. So these are those suction devices. This is that mushroom tip. That's fine if you're just trying to clean out their nares, but this is what I'm talking about with these RSV kids. You're really going to have to get in there and be aggressive. Your neo sucker will be okay. You're not going to need a yank hour on these kids. You're going to cause a lot of trauma if you do that. And like I said, this is just basic. These are two of the same things, basically. But there's lots of good suctioning, pediatric suctioning videos if you need to get a little more comfortable with that. You're going to measure it the same way. You're going to measure it the tip of their nair to their ear. That should get you that posterior pharynx. And then you can even go a little bit further than that if you want to be able to initiate that gag reflex for them to start doing a more effective cough. But don't just bury it until you reach resistance, because it will cause some airway trauma and bleeding on these kiddos. All right, we're not going to talk too much about croup. We barely have to ventilate a croup kid. And think about if you do, once you get that tube placed, because that's the problem really, is their airway, they shouldn't, croup is not, it's an upper airway problem, not a lower airways problem. So I'm just going to kind of cruise past this a little bit. But intubation is the hard part here, and making the choice to intubate a croup kid. The minute that with that kind of infection, and swelling that's happening in their throat can easily transfer and go up into their epiglottis. So when you put a laryngoscope in their mouth, easily their epiglottis can swell really quickly. And the minute you try and pass a tube, you may only have one shot. So this is a kid that is needs to go to the OR and be intubated under anesthesia. This needs to hopefully not be a crash airway for you. These kids do really, really well with just keeping them calm. Racemic epi is going to help these kids, and cool mist is going to help these kids. You're probably going to have to keep your parents close by and stuff like that, and try and keep them from crying and making that airway swell even more. So, and then that whole inside outside thing will normally help. A lot of times just moving them to the ambulance and that kind of temperature change will help with that cool air and help decrease that swelling in there. So. All right, so we've seen a lot of influenza problems this year, and they are equating it basically, and they're calling it just like when we had our H1N1 influenza scare. I don't know, I think it was like back in like 2006 when H1N1 hit, but our flu season has been a lot like that. Sean can attest to this too. We've taken a lot of 30, 40-year-old, previously healthy, no comorbidity, people my age, normally healthy, came in with the flu, got Tamiflu, got sent home 2 days later, is back in full respiratory arrest, and we're transporting and putting people on ECMO kind of frequently this flu season. So, so be aggressive with your flu treatment. That's where we're headed. This is going to basically just overwhelm their lungs. It's going to cause, these patients are going to end up with pneumonia and then progress to ARDS really quickly. A lot of times within less than 12 hours of their initial diagnosis. So just be prepared with these patients when they look bad. They're most likely not going to get better with albuterol and things like that. They're only going to progress, especially if you pull a chest x-ray and they already have signs and symptoms of pneumonia. So a pneumonia post-flu diagnosis is a very bad sign. And then they're just having crazy inflammatory responses to this virus this year, this strain of the flu, and it's causing that ARDS to happen. It's causing that MODS, that multi-organ dysfunction syndrome to happen, just end organ failure. These patients are getting so sick so quickly. Remember that your kiddos are not going to be able to tell you like your adults. So they may be nauseous, they may be vomiting, they may have diarrhea. So our kids that get dehydrated really quickly don't do well. If you dehydrate a pneumonia patient, their VQ mismatch gets even worse. So you want to keep them hydrated, keep those fluids moving, keep those secretions nice and loose and moving so you're not creating concrete in their lungs, basically. So I use this picture a lot of times in a lot of my presentations. I like to talk about it for a couple different reasons. Number one, that kid looks like garbage. If you have a kid that is flailed out, looks like he's sleeping, first responders are touching and bugging him and he doesn't care. This is, you walk in and it's that, oh crap moment. I need to do some stuff really quickly. Number two, one thing I like to point out, especially when we start talking about adult teams taking care of kids, or like me, I do 30 days and above. Look at this non-rebreather on this kid. This is an adult, or at least a pediatric. It's not an infant, but I'm pretty sure it's an adult non-rebreather. Even with 15 liters of flow, there's dead space in there. So number one, I don't think that kid is supporting his own respiratory rate. He probably should be being bagged right now. But number two, if you're trying to give him oxygen, putting an adult device on him, so bagging him with an adult BVM, using an adult non-rebreather, this kid is rebreathing CO2. So you're going to automatically make his problem worse. And then if something happens and this kid gets popped off oxygen and people don't notice because that bag stays inflated sometimes even without flow, this kid will just be rebreathing all his exhaled CO2. This kid can get so worse so quickly. So I like to urge people, there are great pediatric kits out there. We're doing a lot more stuff with the Hand-Heavy and things like that. Peter Hand-Heavy is a great doc to talk about that kind of stuff, and our Certidose and things like that. But we really need to have pediatric respiratory devices available. And I know it's hard in these rural agencies. You don't have a ton of money, but you got to have a good PEDS kit that you can take care of these and bridge these patients until you either get a helicopter critical care or get them to the hospital, because you could be making these kids worse just by, you think you're doing the right thing, you're putting a non-rebreather on that kid. It's just too big. So just think about those kind of things. That's one of my little, I really try and urge people like me. I take care of adults 99% of the time, but don't try and make our adult equipment fit our kiddos. So we talked about this. This is just this rapidly progressing type of illness. They're going to rapidly go from pneumonia to respiratory failure to ARDS. So now we get to talk about our ARDSNet protocol. I think I have a slide in here. If not, I would urge you guys to look at that. A lot of our aggressive ventilation strategies came from that ARDSNet study a really long time ago, and it is very effective. So even if you're going to use pressure control or volume control, you're still doing ARDSNet protocols. You're still allowing for lower tidal volumes, that 4 to 6 cc's per kilo. You're doing your high respiratory rates, and you're doing your high PEEP, those three things that I talked about. So if you say, all right, this patient looks like an acute respiratory distress syndrome, it's not one or the other. So I see a lot of teams saying, oh, well, he's an ARDS. So instead of, for your adults, instead of 500, he's on 300, but I still have a rate of 12 and I have a PEEP of 5. That's a no-no. If you're going to do the ARDS protocol, you need to do the whole thing. And when you pull it up, you'll look, and there's a big, big emphasis on PEEP. So people get really scared of PEEP. These patients that are on ARDS, 10 easily, and most of the time 20 of PEEP. So this is not what's going to pop pneumos, your respiratory compliance, patients, that inspiratory pressure. So a lot of times PEEP is not what causes pneumos. It's aggressive inspiratory pressure. So that big squeeze you do on that bag, or if your vent is pushing in 50, 60 centimeters of water pressure, that is what is going to give you your pneumo. So people are very surprised by the amount of PEEP that these patients need, but they are the epitome of a VQ mismatch. So our pediatric population doesn't weather the flu very well. We all saw what kind of happened this year, and the flu was, and then think about, you're over a 20% mortality rate if you have to be intubated and ventilated because of the flu. All right, so here's our treatment strategies. If you know you're headed that way, intubate early. And this is a different strategy than we think about with our asthmatics. So we try and prolong intubation for asthmatics as long as possible. But with this, you know that they're going to need a lot of help when they start thinking about the amount of fluid in their chest and overcoming this pneumonia and overcoming this influenza. They're going to need time to heal while those antibiotics kill this infection. So intubating these patients early is important. And then those lung protective strategies, you're going to implement those ARDS protocols really early on. And then depending on where you work, you're going to aggressively fluid resuscitate these people. You don't want them to become dry and those secretions to get dry. You're going to have hypotension issues. So you're going to have to walk that line. A lot of people say, well, on transport, you know, I have 10 a PEEP, and then their patient's hypotensive. So that's fine, because it does impede venous return. That is a very real problem. But here's also the problem. If you have a sepsis issue and a respiratory issue, you have to treat both. You can't say, all right, well, my sepsis is causing hypotension, so I'm going to not have more than 5 a PEEP on there, and I'm going to allow for really crappy sats the whole time. You have to do both. So this is the scenario. What kind of pressors do you have available to you? If you're kind of old school and don't have a lot of protocols, or you're in a rural area, you're probably stuck with epi or dopamine, but that's very appropriate. You have to support their blood pressure, so you have to support their circulatory system, and you have to support their lungs. They're going to need more PEEP. So you're going to have to add in your pressors and walk that line. So just something to think about. You can't do one without the other with these patients. You have to do both. So we're going to, when we decide to ventilate these patients, like we said, we're going to do those low tidal volumes, those increased PEEPs, and those increased respiratory rates. And we're going to allow, we're not going to need to normalize their CO2. because this is going to be a long time process of ventilating this patient. So permissive hypercapnia, depending on what kind of protocols you have, is normally in the 60s. And I would be fine with that as long as I'm oxygenating. So think about hypoxia is going to cause more devastating injuries than increased hypercapnia or increased CO2 problems. So we need to make sure that we can kind of deal with our CO2 problems, but we really are effectively pushing in oxygen as much as humanly possible on these patients. And when I talk about our H1N1 patients, I'm referring to this is going to turn into that acute respiratory distress syndrome. So just treat it just like you would any ARDS patient. All right, I'm not going to talk too much about our pulmonary contusions. We all know that our kiddos are going to have a bigger chance of pulmonary contusions based on how pliable their chest wall and their rib cage is. They all along where their ribs attach here to their sternum, they have tons of cartilage still. That's not all a bony process yet. So they get a lot of flex in their chest wall. So their lungs tend to take the hit for that. So just remember that your kiddos that are in car accidents and falls and stuff like that, you are going to deal with pulmonary contusions a lot more on babies than you will adults. You're going to deal with rib fractures more on adults and some smaller pulmonary contusions, but that's mainly a kid problem. They usually develop in 12 to 24 hours. I will tell you that if you can see a pulmonary contusion on a chest x-ray in less than 12 hours, that's a bad pulmonary contusion. So just think about that. So that is that big bruise that happens. They get an insult, they get some leaky capillaries and blood leaking in that lung, and that's going to cause a VQ mismatch. And I'm pretty sure you guys are going to be sick of hearing me say that, but it is causing a physical barrier to diffuse CO2 and oxygen in their lungs. So just think about a big old substance sitting right here, preventing the oxygen you're dumping in from getting into their circulatory system. And then that circulatory system is bringing CO2 back out, but it's not able to escape into the lungs to be exhaled out because of that physical barrier. So these kids are going to be harder to ventilate depending on which lung too. So if it's bilateral, you're really going to have some problems. This is going to be closer to an ARDS setting. If you have bilateral pulmonary contusions, you're not going to be able to put in high volumes and high pressures. These lungs are going to be too stiff for that. So you're going to have to do lower tidal volumes strategy. If you're going to stick with a volume control setting and pressure control settings, you're going to have to allow for lower exhaled tidal volumes as well and just compensate with a rate and PEEP. So think about PEEP here. That's really going to be a lifesaver for these kiddos here. That PEEP is really going to push past that physical obstruction and allow that oxygen to diffuse in. Just another picture of the pulmonary contusion. I'm pretty sure this is an adult. So like I said, similar to ARDS settings, you're going to do lower tidal volumes, fast rate, increase PEEP. And then if you still have problems with oxygenation, a lot of people think, well, I'm on 100% FiO2, I'm on 10, 15 a PEEP maybe. Where do I go from here? Like, what else do I do? Like, when the heck am I going to be at the hospital for someone else to do something? We have a little bit extra, depending on your protocol. Some places allow paramedics to manipulate eye times. Some people don't. Here in Colorado, your Denver Metro protocols, unless you're a CCT paramedic, you're not allowed to have a ventilator that will manipulate eye times. So in this setting, if I had a patient like this, so an ARDS patient, that could be pulmonary contusion, drowning, pneumonia, anything like that, that is going to progress into that ARDS, that acute respiratory distress syndrome. I'm going to think about, all right, so I'm on 100%, I'm on 10 to 15 a PEEP, and my stats are still garbage. What do I do now? You can start messing with your eye time. So think about when we had a CO2 problem, we lowered our eye time to give ourselves longer expiratory times. This is an opposite strategy. So you are going to increase your inspiratory time and decrease your expiratory time. So all I have to do is hit my eye time button, my I to E ratio will come up, and then I can use my toggle switch and turn up that inspiratory time. So if you were on a kid, you were probably somewhere around 0.5 or 0.6. You can start dialing up that I time, and you are starting to move toward a 1-to-1 IE ratio. And especially if you guys have a chance to set up your vent and look at this and watch what happens. So what you're going to see is, instead of that opening and closing for longer, you're going to see open, 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 close, open, 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 close. So think about that during that open, open, open period. That is where your PEEP is able to drive that oxygen in and push. So if you can maintain that phase of ventilation longer, you will be able to drive in more oxygen. So now if we take that a step further and we think about, all right, so we're gaining some ground, but not enough. Now we're going to think about a 2-to-1 IE ratio. And so I tell everybody, if you're in pressure control ventilation with a 2-to-1 or a 1-to-1 IE ratio, this is really for, especially for adult teams, this is the most aggressive form of ventilation we're going to be able to do. Our pediatric and our neonate teams have access. This ventilator over on the side is a high frequency ventilator. They're going to have access to things like that, our high frequency ventilators. We don't have access to that. So this is going to be our kind of last ditch effort. A lot of times in the hospital, these patients will be proned. That is not something we really do on transport. I will tell you, it's not impossible. I'm seeing teams start to do it, and I am not adverse to it. In fact, I've kind of been thinking about it more and more and more about when I would get to the point where I would think about transporting a patient prone. That's going to cause a lot of issues depending on what kind of aircraft you have. But in the ambulance, I feel like it would not be too much of an issue. You would have to keep them paralyzed and sedated during that period because you don't want them waking up, moving their head, things like that. But that's kind of your progression here. So your 2-to-1 IE ratio, you're going to think about, they're going to be open, 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 shut, open, 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 shut. And what you'll see on your test lung is it's going to open, and then there's this really awesome pause that happens, and that is pure oxygenation being driven in. So that is mainly what our high frequency ventilators do. It's just open and driving in oxygen. There's no opening and shut of those airways. It's just maintaining an open airway, pushing in oxygen, pulling out CO2, pushing in oxygen, pulling out CO2. So that's all the great things that happen. So for us, pressure control ventilation, 2-to-1 or a 1-to-1 IE ratio in your ARDS-NET protocol. So those allowing for lower exhale tidal volumes, increased respiratory rates, increased PEEP. That is the most aggressive form of ventilation. I don't have to do that too often, but I will tell you that IE ratio, being able to manipulate that, is a true lifesaver. Depending on if you go on a place that has been trying to maintain an ICU patient for longer than they should have, and now they're in a world of hurt. They're realizing that this patient needs to be on ECMO, and now you have an hour transport to an ECMO center. What are you going to do for that hour? Most of the time, they're not going to have thought of what you think of. Most of the time, these patients, a lot of times, depending on what kind of rural facility you have, there's not even a doctor there. So maybe they haven't even done any of the settings we talked about an hour ago. Maybe they have only done volume control ventilation, and maybe just by going into pressure control ventilation or your ARDS-NET protocols, you're going to be able to transport this patient. Every once in a while, you're going to run into a place like where I work that have done all these aggressive settings and even prone to patient, and now they're like, oh man, we got to go to a bigger center. And sometimes they'll even place them on ECMO before we leave. But those are some things to think about when everything we talked about for the last hour is not really working. So obviously this is late in the game for this conversation, but this is where we're talking about why we're going to determine to intubate these kids. They are, your acute hypercapnic respiratory failure. They're your circulatory collapse kids, your respiratory collapse kids, all those things. So we all know why we intubate these kiddos. Depending on what kind of ventilator you have, and then what mode you're in versus volume versus pressure control ventilation is where you get to get kind of nerdy with this stuff, and you get to start manipulating kind of your flow patterns and how your vent delivers breaths. So that's something you should know about your ventilator if you transport with one, is what kind of flow patterns does your ventilator have? I have a ventilator that does not have a graphic screen, which is kind of a bummer, especially for an RT on transport. I love being able to see that kind of stuff, but just knowing what kind of flow pattern I have based on if they're in volume versus pressure, and able to manipulate things like my rise time and my flow termination and things like that. So really getting nerdy with your ventilator is pretty important. When you start transporting patients that require different kinds of ventilation than just our normal volume control ventilation, you're going to need to know how to manipulate these things. So you can think about a lot of our normal ventilation is this square waveform. When we talk about accelerating and decelerating flow patterns, that has to do with different kinds of oxygenation. But remember, this all has to be, what are you comfortable? How well do you know your ventilator? You don't have to nerd it up like me, like an RT. I work with tons and tons of smart paramedics that know exactly what they need to know about that ventilator to manipulate anything that I do. So just remember, we've talked about all those awesome ventilation strategies, but there's also little tweaks depending on what kind of ventilator you have. You can mess with that flow pattern. You can mess with the inspiratory flow, all those kind of things you can mess with. So point of this slide is to get nerdy. All right, so we talked about, oh God, when things don't work out. Let's talk about where you're gonna start. So you go on an interfacility call, or you are a 911 ambulance that has this. You're gonna start out, for me, this is the mode that I'm gonna start out in, and it just has to do with the Revell ventilator that I use. Make sure that you're comfortable with whatever vent that you use. But this is synchronized intermittent mandatory ventilation with an added mode called, and it's a volume control mode, that VC, but it's pressure regulated. So if you're in a different kind of ventilator, this may be called APRV or something like that, airway pressure release ventilation. But basically in my vent mode, this means that I'm gonna be delivered a set amount of tidal volume every breath that the ventilator gives, but each breath, my vent is gonna give it at the lowest amount of pressure. So sometimes it might take 20, sometimes it might make 30, but every breath is gonna be different. So that sounds great, right? Normally it is. Where we start seeing problems with modes like this, with this PRVC mode, is that sometimes you have patients, especially like our STEMI or our post-heart patients, where they don't tend to like inconsistency with pressures and volumes and things like that. So think about that. You take a big insult to your left ventricle, that left ventricle is constantly trying to figure out how hard it has to push in order to maintain your blood pressure. So it's evaluating what kind of systemic vascular resistance you have. So what is your extremity pressures, and what kind of pressures are going on in your lungs, and what kind of pressures are you putting in your chest. So if you have changing blood pressure and changing pressures in their lungs, which is exactly what you're doing with PRVC, your left ventricle has a really hard time figuring out how to maintain your blood pressure. So I would say in your STEMI patients, your post-heart patients, things like that, SIMV is fine, is a great mode to be in. It's and I'll tell you the difference in just a second between that and AC, but just being in a straight volume control mode, so that you're delivering that same volume at the same pressure every breath, is kind of important for these type of patients that have a really grumpy left ventricle. So SIMV, synchronized intermittent mandatory ventilation, versus AC, assist control ventilation. In my ventilator, when I click on this, it allows me to add what is called pressure support. That is different than pressure control. So so let's say you set up this vent, you're ventilating this kiddo at 20 breaths per minute at a tidal volume of 100 cc's, and your I time is 0.7. You have 5 a PEEP, 100% on your ventilator. And I have an option now for pressure support. What is that going to do? That is going to come into play on my spontaneous ventilations. So your patient is getting 20 breaths per minute from this ventilator, but they have an intrinsic rate that's higher. So your kiddos most likely are breathing a total respiratory rate of 30. So that means 10 breaths per minute, they are breathing without the ventilator. So what do we have to do? We have to give them a certain amount of pressure and a certain amount of help to overcome that ET tube and all the dead space we created and the resistance in the circuit, and help them augment and create their own tidal volume. So what that's going to do is you can set it anywhere. I think it goes up on my vent, it goes up to like 20, I think. So 5 is a normal starting place for kids. So you add in 5 of pressure support. So that means when they take a spontaneous tidal volume, they're going to get the PEEP that you set. That is all the time, no matter what. But on top of that PEEP, it's going to go 5 above that. If that's what you set, 5, 10, whatever. It's going to give 5 above that, and it's going to help them pull a really good tidal volume through that circuit. So this is a really big deal for us. We've had a lot of focus on this, especially in Colorado with our children's hospital, is making sure that we are adding in enough pressure support for our kids that are breathing well over our ventilator. And making sure, so think about that, they get 1 good tidal volume with their vent-initiated breath, and then they take a spontaneous breath, and without pressure support, they're either getting barely anything, or if they're in AC, they're getting that full volume every time. So think about how we breathe. Normally, we don't like to take the same tidal volume over and over and over and over and over again. Every tidal volume is different. So forcing them to be in assist control mode, every time they ask for a breath, they get that set tidal volume, can be very, very irritating early on. Adults or kids, doesn't matter. This comes into a little bit more of a play with our kids because they have a higher intrinsic rate above the ventilator rates that we set. So if that's something that your vent has, you might want to do some more investigation about what kind of pressure support settings you have. So you would be going up and able to look at that and say, go into your back menu or your monitoring menu, however you go and evaluate your peak inspiratory pressures, your IDE ratios, your exhaled tidal volumes, all those things. You should have up there your VTE or your exhaled tidal volume, and that has to do with your ventilator initiated breath. And then it should say spontaneous or SP VTE for your spontaneous tidal volumes. That's where you evaluate if you have enough pressure support on there. So if you look at that and you're shooting for 100 cc's on this kid, you've calculated out 8 cc's per kilo, and on your volume, on your tidal volume and your ventilator initiated breaths, you're setting it at 100. You want to help augment their tidal volume, their spontaneous tidal volumes close to that, so they can pull that if they want to, but they don't have to if they don't want to. So if you have a really low spontaneous exhaled tidal volume, you need to increase the amount of pressure support for these kiddos so they can maintain a really good minute ventilation. Sorry, that was super long. If you guys have questions about your specific ventilator, feel free to send me an email. We can set up a live chat session, something like that, to troubleshoot your ventilator. So for a normal, when we talk about this, 6 to 8 cc's per kilo, that's what we're shooting for on all of our adults and our kids. Like I said, I've read several books, and even everywhere I can find, 8 cc's per kilo is our new target tidal volume, 6 if their lungs are sick, and then we'll tolerate 4 if we need to. But I'm always shooting for 8 cc's per kilo right off the bat. You're gonna pick a decent respiratory rate, 20 to 40, like we talked about our I times. Depending on what mode you're in, be careful. And every ventilator is different. I'll tell you, with our ventilator, our issue is that if we pick infant mode for a ventilator, it locks us into a 0.3 I time. That is a very aggressive I time for a pediatric patient. That is a 0.3 and 0.4 is something that you deal with in the NICU population. So if you have a 1 or 2 month old baby, locking them into a 0.3 I time is a problem. What you'll go up and you'll look at your I to E ratio, and you'll be somewhere around 1 to 9 or 1 to 7, which is crazy. We should not be shooting much past 1 to 4, 1 to 5 for our restrictive process or obstructive patients. So if you have a baby that you just lock them into a 1 to 9 IE ratio because of an I time that you can't manipulate, you're gonna have end-tidal CO2 problems no matter what you do. No matter how low you turn down that rate, they are going to be exhaling so much CO2, you're going to have no control over that. So here's some normal PEEP settings for you. I'll tell you, NICU transport, adult transport, PICU, adult ICU. I've never done less than 5 centimeters, even on really sick babies and things like that. But depending on your comfortability level or your protocols, you may be asked to do less PEEP than that. And that's just something you guys will have to know for your protocols. 99% of the time on transport, and this is what I tell even my own team, stop worrying about titrating oxygen on these babies. I think for a long time it was driven in, especially on our cardiac patients, don't hyperoxygenate these patients. The problem is that 99% of our kiddos that are on the vent are on there for a respiratory problem. So the hour that you have them and give them 100% is not an issue. So if you have people that are constantly focusing on, oh my God, they're 100% saturated, I need to keep turning down this oxygen, they're sick. They're in your ambulance, they're in your helicopter, they're going to the hospital, things look like garbage. They deserve 100% until they can get more stabilized, and then the PICU or the ER, things like that can start titrating that down. This is my opinion. Remember, you're going to have to follow your protocols or what your physician advisor asks you to do. But in my opinion, this is the way that I practice. And then this is that pressure support setting that we talked about. 5 is kind of normal, but don't be afraid to go up to support their spontaneous tidal volumes. All right, and we talked about this, when to deviate. So our previous slide was normal ventilation. You walk in and your kiddo is a seizure kid that they just over-narked. So they can tolerate 8 cc's per kilo versus when you go in on your post-drowning kid who they're having trouble ventilating and tons of secretions, tons of water, whatever, lake water, whatever it is in there messing with their lungs. That's a sick lung. That's going to be that 4 to 6 cc's per kilo. When we start talking about these restrictive issues, we start talking about different kinds of respiratory rates. So if you have an asthmatic, you're going to have lower respiratory rates so that you can have your I to E ratio of 1 to 4. In our previous setting, when we just talked about our ARDS patients, those patients have higher respiratory rates to compensate, but we are not shooting for a 1 to 4 IE ratio on our ARDS kids. We're shooting for a 1 to 2, and then depending on how sick they are, a 1 to 1 or a 2 to 1. So those are those main differences between restrictive and obstructive issues where we're trying to blow off CO2 versus an ARDS problem, which is an oxygenation problem, and we're trying to drive in as much oxygen. Remember, shorter than a 1 to 0 I to E ratio, our kiddos deserve a little less. This is really an adult I to E ratio. So I tell my team 0.5 to 0.7 is an issue, is a good place for us to be, and then PEEP of 5 or greater, 100%. Remember, I talked about these kiddos have really fast metabolism. So yes, they can absorb this oxygen quickly. They can also desat really quickly. So I feel like they're sick enough to deserve me in the helicopter. They're sick enough to deserve 100% till someone else can deal with that situation later. All right, so we kind of have been switching back and forth and talking about this back and forth already, but depending on what kind of ventilator you have, if you have the chance to switch into pressure control ventilation and you have a kiddo that's failing volume ventilation, that is what you're going to have to do. If you have a kid that's failing volume control ventilation and that is the only type of ventilator you have, you may get to a point where you have to take them off and bag them, and that is just going to be part of your clinical judgment to know that, hey, this ventilator is not cutting it anymore. I'm going to need to do this myself. And if you think about that, when you push in on that BVM, that's an inspiratory pressure. When you have a PEEP valve on there, that's an expiratory pressure. You're positive pressure ventilating that kid. So treat that BVM like you're pressure control ventilating that kid. Don't force in volume that doesn't want to go in. Make sure you have a PEEP valve. I mean, how long have we been talking about this? And really, tons and tons of agencies still don't ventilate with PEEP valves. The minute you take over a kid's airway, you need to be adding back in what you took away. So there's lots of discussion about whether or not people maintain an intrinsic PEEP. What I will tell you is that they do maintain a pressure. However you want to call that, if you want to call that their FRC, their functional residual capacity, when you exhale normal everyday ventilation, you don't exhale everything in your lungs. So when you put an ET tube in there and now you've just created equal pressure from the inside to the outside world, you've taken away whatever FRC or intrinsic PEEP that they have. I mean, we can discuss whether I'm seeing a lot of different agencies and places talk about no such thing as intrinsic PEEP. That's fine if that's what you want to say. There's something in there. There's volume. Volume can equate to some sort of pressure. Maybe that's where people are getting the intrinsic PEEP name from. But either way, you have now taken away their ability to keep a certain amount of distending pressure in their lungs or distending volume. So you need to give that back. So PEEP is really important on these kiddos. And so bagging without a PEEP valve is not a hot move. So we really need to step up our pre-hospital game. Our BVMs need to have a PEEP valve. If we can step it up even further and use anesthesia bags, that's amazing. But that may not be something that is available to you because you have to have a gas source always to be able to use that kind of mode of ventilation. So whatever you have, but I am guaranteeing you that we can BVM ventilate, bag valve mask ventilate these babies way better than we have. So I tell people, especially when I go to pre-hospital agencies, a lot of times you'll see those paramedics, they want to move on to bigger, better scenarios. They want to move on to intubation. They want to move on to pushing drugs, things like that. What I will tell you is that airway should not be given to the least experienced person in that room. I see a lot of times, you know, that brand new EMT is the one that gets stuck bagging that patient. As a paramedic, how I ventilate those lungs is the #1 priority. And especially as an RT, it's my #1 priority. But if I go on a kid that I have to intubate and ventilate because of respiratory failure, their lungs are sick. So that is the one thing I want to be paying attention to. So I want to feel that ventilation. What I will tell you is I do not think you can accurately feel compliance with a BVM. If you can feel resistance, that's a tremendous amount of resistance in their chest. With a pediatric anesthesia bag, you can tell really quickly and tell dynamically that those things are changing early on. And then you can ventilate every breath that you breathe. You can pick, you know, I'm not going to go above 30 centimeters of water pressure and dial in my 5 a PEEP. There's my 30/5. That's a great way to ventilate a really sick respiratory patient. Most of our BVMs do not have an inspiratory pressure manometer. If you do, you guys are well ahead of 99% of the agencies I've dealt with. Even my own agency early on didn't have PEEP valves available to them. I remember being a respiratory therapist on a critical care team 10 years ago, and I didn't have PEEP valves available to me. And people looked at me like I was a crazy person every time I said, can I have a PEEP valve? So that really should be end of discussion. That should be happening, or you should be moving toward that. If that is your mode of ventilation for these kiddos is BVM ventilation, you should have, we should be able to BVM ventilate these kids better. Remember that it's a nice soft squeeze. I talk about, especially with our bigger guys, our bigger firefighters and stuff like that, no two-handed bagging. Even on our adults, there should be no two-handed squeezing. If you squeeze that whole bag and those 2 pieces of plastic touch and you deflate that whole bag, that is over 1,000 cc's for an adult bag. It's over 500 for a baby, for our pediatric bags. So I'm talking about decreasing the amount that you bag and the pressure that you bag with by 50%. So your fingers should never be touching each other. Those 2 pieces of that plastic ball that you're squeezing should never reach each other. It should be a nice, slow push to pressure. You don't need to push past inspiratory pressure. And if you have, and you're having to tolerate lower tidal volumes, you're not able to push in the volume that you want to, then bag a little bit faster. Increase your respiratory rate, just like we've been talking about. If you're the ventilator, do what you would normally do, which is lower tidal volumes, faster rate, dial up your PEEP valve. So you can do what the ventilator does in a ghetto kind of form, I guess. I don't really want to say it that way, but you can ventilate them like you would on the ventilator. You don't have as many options and alarms and things like that, but mimic what you would do on the ventilator. Don't just hand off that bag to your probie and to your brand new EMT and let him just bag that thing to beat the band. That is not what we do anymore. Ventilation is #1 priority. And I know as a paramedic, you're like, yes, I got the tube. This is awesome. We're going to tape this and I'm going to hand it off and move on. Don't move on. This is your thing. This is what you need to be good at. We need to have a lot more focus on our ventilation.
Hey, Melissa. So
Yep.
I don't know if you saw the question. So Brian asked
I didn't. I'm
question.
sorry. I'm over in that private message thing. Sorry.
Yeah, no, that's okay. I think you just answered a lot of that, Brian, and maybe chime in if you still need some more clarification, but on settings that are similar versus different between adults and peds.
Yeah, I'm just looking at some of the ventilators you guys have. I when I move to my next team next month, I'll be using the Hamilton T1, and I obviously know about that vent. It's a great ventilator. I've used the LTV 1200, and I'm sure, Raphael, I'm sure you have a lot of issues switching back and forth between those ventilators. Those are very two different ventilators. And Joseph, you guys are using the 1200, perhaps the Zoll. I have used the Zoll, and I do love that Zoll Eagle ventilator. There's the new Eagle that's out is a great ventilator. That T1 is a great ventilator. I use the Revell, which is the newer version of that LTV. What settings are similar between peds and adult, and what are different? Correct me if I'm wrong, but PEEP, PIP, PPLAT, IE, and tidal volume per kilo are basically the same. You're absolutely right, Brian. And that, like in the beginning when I talked about that, you know, we want to talk about anatomical differences, but ventilation is no different. If you have increased pressure in your chest for an adult versus increased pressure in the chest with the kid, you're going to troubleshoot the same thing. If you have a high peak inspiratory alarm, is your tube where it should be? Is your kid awake? Is your kid biting the tube? Is there secretions in the tube? Then you're going to go and look at your circuit. Is your circuit pinched anywhere? And then if you've eliminated all those external things, then you trust your ventilator. There's a high peak inspiratory pressure. Your lungs are getting stiff, or you're filling with pulmonary edema, or whatever's happening. All those things are the same. You're going to pick 5 a PEEP on adults and kids. Your peak inspiratory pressure, you're shooting somewhere between 20 and 30. Your high peak inspiratory alarms, you don't want those above 40 unless you're going to switch into your pressure control mode and you're going to allow for higher pressures to give you those lower tidal volumes. Your plateau pressures, between 30 and 40, you need to be figuring some stuff out. We don't want to maintain plateau pressures above 40. Your IDE ratios are exactly the same on adults versus kids. If you have an obstructive or a restrictive issue and you want to blow off CO2, you want to be at a 1 to 4 or 1 to 5. If you have a hypoxic, a oxygen issue, then you are going to be at a 1 to 2, a 1 to 1, and then a 2 to 1 as you progress through those issues. And then your tidal volume per kilo, same thing, adults versus kids, 8 cc's for good lungs, 4 to 6 cc's for bad lungs. So I'm trying, and I hope I've done that today. I've been able to eliminate, kids are not that different. They have the same problems that adults do. Adults have asthma, kids have asthma. Adults drown, kids drowned. Adults aspirate. Most of the time they aspirate vomit. Kids aspirate other things. Like we talked about, like the Tide Pod and things like that. So all we're really looking at when we look at different things with our kiddos, you're right, is our vital signs. So our respiratory rates are going to be higher. Our exhaled tidal volumes are gonna be lower. Our cc's per kilo we just talked about will be the same, but our exhaled tidal volumes will be different. We'll have more aggressive I times, obviously, on our kiddos. Those are those unique values. You're exactly right, Brian, for each and every age group that you deal with. Same thing with our adults and our kids for our blood pressure and our heart rates and things like that. The theory is the same, ventilation. So I'm hoping that I eliminated that for you guys today, to know that your ventilator theory on your ARDS patients for your adults are the same if you're going down that ARDS route with your kiddos. Don't be afraid. Don't be afraid for PEEP for these kiddos. Don't be afraid for pressure control and higher pressures. If anything, our kids' lungs and their chest walls are more compliant. You know, most of the time they don't have COPD, they don't have those types of things, and pulmonary and emphysema and stuff like that. Their lungs are pretty compliant. They just have an infection or an insult or something going on that we're going to get them through. Did I answer your guys' questions for that part?
I have a question for the group out there, and you can leave your comments in the boxes. Is anybody doing pediatric ECMO transports? So I'm just curious if anybody's doing that.
Okay. So I'm not going to hammer this home, but when we talked about where to start, a lot of times that's what people ask me. Okay, so I decide that I can't volume ventilate this kid and I'm going to have to go into pressure. Where do I even start? So hopefully this is the second or third time you heard me say this. Look at your peak inspiratory alarm. Where was your vent cycling off at? When I picked this setting and I decided to say greater than 25, honestly, if you are failing volume ventilation and you pick 25/5 for your kid, that is not going to be sufficient. If you were popping off and venting your volume and your pressure at 40 centimeters of water pressure for your peak inspiratory pressure, 25 is going to do jack nothing for you as far as your exhale tidal volumes go. So think about just setting that where that is. If you don't want that baby to be ventilating over 40, then you need to set your vent at 40. So for me, on my vent, because it's not PEEP compensated, I would set my pressure control setting at 30 and my PEEP at 10, or my pressure control setting at 35 and my PEEP at 5. That is probably different for a lot of your vents out there. I can't remember with the 1200. I'm pretty sure a lot of those have an external PEEP valve, but I know that T1 is steps above a lot of our ventilators right now. So you guys are pretty lucky if you get to use that vent in your transport. I'm looking forward to have access to that ventilator pretty soon. So, so I say greater than 25, but honestly, you need to look at that peak inspiratory pressure alarm. And if you say, all right, we're going into pressure control, folks, you need to pick that. You need to pick your high inspiratory pressure. So that's honestly where I see people fail pressure control ventilation, is that they're just really scared to pick those higher pressure control settings. And then your patient is automatically being underventilated. Their SATs drop. Sometimes they get bradycardic and you're like, screw this ventilator. This thing is not working. It's not doing what I want it to do. I'm just going to take them off and bag them. So honestly, that's where I see a lot of issues coming in. So remember, when you pick your pressure control settings, you're allowing for a higher respiratory rate because you're allowing for a lower exhaled tidal volume. Your PEEP, you're going to be 5 to 10, your I time 0.5 and greater, depending on what kind of strategy you're doing, whether you're doing a restrictive obstructive strategy or if you're doing a hypoxic oxygenation issue ARDS type of strategy. And then remember, I'm an advocate for higher oxygen on transport. We don't need to be dealing with another thing. If you're like me, there's me and one other person in the back. If I'm dealing with all these other issues with the ventilator and watching my baby's vital signs and dealing with pumps and pressors and IV pumps and all those types of things and maintaining my baby's temperature, which is super, super important, not having to deal with that FiO2 is one less thing off my plate on transport. And then if you decide to go into these pressure control settings and your kiddo is fighting you and their lungs are getting sick and sick and sick, make sure you paralyze and sedate these kids. You want them to stop participating. They're not doing a good job. Their brain is on overload and can't fix it. So paralyze and sedate these patients for sure. And meds. You know, if you, if this is a restrictive patient and you're asthmatic and you're going downhill, you should have had sub-Q epi, but make sure that epi drip is cranking. Make sure that you have given mag and turb and redose those if you need to. Give your Solumedrol. If you have different kinds of steroids available, give everything. If this kiddo is going downhill, give everything you have. And then one thing I think about people don't think about a lot of times is that these kids are dry. So remember that you have to, they're breathing. Think about your OB patients that kind of do that panting breathing. They dehydrate themselves really quickly. Depending on how long this kid's been sick, they're exhaling a lot of their volume and a lot of their good volume for their systemic vascular resistance. So just by maintaining these babies' blood pressure and giving your fluid boluses, your 20 per kilo and stuff like that, give a couple fluid boluses, see what, as long as your kid doesn't have a cardiac problem, that should help a lot. All right, so we've talked about normal ventilation. We've talked about where to start with normal ventilation, where to deviate when that starts to go wrong. We've talked about our aggressive pressure control settings. We've talked about our ARDS stuff. We talked about when it's hard to push in pressure, when it's hard not to, all those types of things. And then these are this kind of, oh crap, these, and this is the last slide I'll leave you guys with, is, you know, when none of these things work, that may be all you can do on transport. This picture over here is that high frequency ventilator. A lot of times that's what this kid is going to need. This kid is over here on ECMO and this patient's prone. A lot of times these really sick ARDS patients, these bad VQ mismatch patients, adults or peds, this is their course of treatment to fix them at the end. One of the good things I think about when we talk about kids is that I see a lot more aggressive use of our high frequency ventilators our ECMO and our prone positioning in our kids. A lot of times we don't see adult ICUs using our high frequency ventilators, or they don't realize how efficient they are. And a lot of times you're crashing patients on ECMO, where I see a lot of pediatric centers initiate ECMO early on. They just anticipate these kids not getting any better. So if you're an advocate for that patient and you're thinking about, hey, where should I transport this patient? If you're comfortable with that baby even longer in the back of your ambulance, take them to a place that's going to do these things for them. If you take them to a rural center, you're going to delay their transport. If that's all you have, obviously that's all you have. But if you are like me and you get to kind of pick where you take your babies, I'm going to always pick a place where they are going to get the absolute most definitive care possible. So they're going to go to an ECMO center. They're going to go to a place that has access to high frequency ventilation and things like that. And then, you know, I'm hoping that before my career ends in transport, that I'll be doing some prone ventilation on transport as well, and really push my limit and my comfortability there. So, all right, guys, I think I've talked at you for long enough. Does anybody have any questions or scenarios they want to throw at me?
I think that's awesome. Awesome stuff, Melissa. Yeah, we'll open it up. We'll give you guys about 10 minutes if you've got questions that you want to type, or you, like I said, you can raise your hand and I think I'd be able to turn on your camera if you would like to just speak to Melissa. We can do that. I know that, you know, pediatrics always terrify most people, and especially when you start dealing with these kids that are vented. And I think it's a really good point that you make, Melissa, that, you know, basically our starting numbers, basically our values are, for the most part, the same, you know, especially with those healthy kids. Of course, we need to make sure that we're adjusting our volumes adequately. But, you know, when we're adjusting our volumes based on the patient's weight, and you mentioned a little bit about ARDSNet, and with that, we talk about ideal body weight. And of course, with kids, they're usually are pretty close to their ideal weight. I think that that's really a valid point to kind of reassure new providers in transitioning into pediatric ventilation. Is the numbers are the same. We're titrating based on weight. You know, kids generally have, you know, healthy lungs unless they don't. But, you know, we don't need to necessarily be so scared of these patients. We just need to be more aware of the changes that we make. So I think that that's a good valid point.
Yeah, I try and stress to people, especially when I teach paramedics and stuff like that, we have to just stop. I think that the pediatric world in general pushed that on us a long time ago, but we have to stop putting these tiny humans on a pedestal. You know, they're sick just like everybody else. They're a sick patient. That's what we do. That's what we're good at. And that's what we're going to go in and do. No big deal. So just remember the little differences between them, and which is really just vital sign issues. But mostly the ventilator strategies are all the same. Be aggressive. Don't be scared of them. You know, we know how to fix them the same way you'd fix an adult.
Right.
Yeah.
Well, I don't see any questions here. If you guys have anything that pops up, you can drop an email either to Melissa. Melissa, do you want to give them your email address again?
Yeah, so you guys can follow me. I have a website, beyondthebvm.com, so you can email me at beyondthebvm@gmail.com. I also have a Facebook page if you look up Beyond the BVM at Facebook. I post a lot of educational articles there, and we can have some fun conversations there as well. And then if you guys have anything specific you want for your agency, or you're interested in having me or Sean come out, please email us and let us know. I am very excited about helping implement pre-hospital mechanical ventilation in the pre-hospital setting. So we're seeing a lot more 911 agencies start to think about that and do that. And I recently helped 2 agencies here in Colorado initiate their ventilator protocols, and now they'll be doing that on all their post-ROSC patients and things like that. So that's my specialty. That's what I'm here for. I'm here to teach our paramedics how to ventilate a little bit better and give them the education that they didn't get in paramedic school. So feel free to email me anything you guys got beyondthebvm@gmail.com, or follow me on Facebook. And then just let me know what else you guys need for your agencies and things like that.
That's awesome. Yeah, I'm super excited. You know, we've partnered with Melissa because she's just amazing. And we know that we can really get the word out and really provide some powerful education to all of you out there. I do want to thank you guys all for kind of bearing with us at the beginning. This is kind of this VILT live online webinar style training is new. We will get the kinks worked out. I am going to be sending out a short survey to your email after the course is done, followed by along with a little quiz. And then once I get those back, I will send out your continuing ed. And yeah, be sure to follow Melissa. And if you have any questions and you can't get a hold of Melissa, you can always send them to me and I will forward them on. If you guys don't have any other questions, we'll wrap this up and say thank you very much to Melissa for your time. This is awesome. And we'll hopefully catch you guys on another class.
All right. Thank you, guys. Thank you, Sean. I really appreciate you guys listening to me for 2 hours.
You're welcome. Thanks, everybody. We'll see you soon.
Thank you.
Bye.